Okay, thank you. Thank you for the invitation. I'm very glad to be here with everyone. I hope you learn from this webinar. And further ado, I think we can start. And as you just mentioned, the topic we're going to have today is hypertension. You can see the presentation. Okay, perfect. So today we're going to discuss primary hypertension. One part of this presentation is going to be regarding diagnosis, the definition of primary hypertension. And the other part, we're going to talk a little bit about the treatment, the target goals we are going to have on this disease. If you have a question, don't be afraid to ask. And I'm going to ask a few questions to see if anyone wants to answer. Okay? And to start with, I'm going to start with a question. And I'd like to know how much you guys know about this disease. So would anyone like to answer this question? What is hypertension? Okay, Ivan or Jennifer?
Jenny, if you want, tell us first.
I'm not very sure about this, but I think it's when you have like high blood pressure.
Okay, yes, it's definitely something related to high blood pressure. But if we want to define hypertension, we want something a bit more complete. I don't know if Ivan wants to add something to the definition Jennifer gave us, or should I continue?
No, I only want to say that is, for example, the strength of the heart bloods the bloods the blood, like something like that. I don't know, but it's strange. Well,
Okay, let's move on with the presentation, and we can say hypertension is defined as a high blood pressure, as Jennifer mentioned. Depending on where you read the definition, it's going to be defined as a blood pressure equal to or above 140 systolic, 90 diastolic. But once again, we require several characteristics to actually diagnose hypertension. The first of them is this high blood pressure, but we also want, or we also require this blood pressure, or this high blood pressure, to be sustained. And this is a very important part of the definition, because blood pressure helps us meet the requirements the body has. And the requirements change depending on what we're doing. So if we're performing, for example, exercise, we require more oxygen in our muscles, we require more oxygen in our lungs, in our heart, in the different tissues. And in order to deliver all this oxygen, the blood pressure is going to increase. So if you took the blood pressure of a person that's performing a very intense type of exercise, he's going to have a very high blood pressure, but that doesn't mean he is hypertensive. When we talk of hypertension, the blood pressure needs to be high when the patient is performing exercise, when he's relaxed, when he's asleep. We're going to have a sustained increase of blood pressure, and this sustained increase needs to remain for at least 1 week. That means if we take blood pressure today and the blood pressure is high, in order to make the diagnosis of hypertension, we would need to see this patient or this person once again in at least 1 week. If the blood pressure remains high in 1 week, then we could make the diagnosis of hypertension. If in 1 week the blood pressure is normal, then this person is a person that had an increase in his blood pressure, but he is we have different ways of making the diagnosis. The most classical way of making the diagnosis would be in the office or in a hospital, where we should make repeated measurements of blood pressure, as I mentioned, at least 1 week apart to be able to make the diagnosis. Or we could also encourage the patient to check his blood pressure at home, to register his blood pressure, and this is going to be called home blood pressure monitoring. Or we have another way of doing this, which is called an ambulatory blood pressure monitoring. And this is a device the patient is going to take to his house. He's going to have a continuous registry of his blood pressure that lasts 24 hours. And we're going to get averages from these measurements. And depending on the average, we can make or discard the diagnosis of hypertension. The classification of hypertension is as follows. So this is the classification of hypertension according to the European guidelines of hypertension, but it is also the definition we have here in Mexico, in our country, and that's why I manage this classification. So hypertension is going to start when the systolic pressure is above 140 in the systolic, and or equal to or above 90 in the diastolic, and depending on the severity of the hypertension, we can classify it as grade 1, 2, and 3. We have another definition which would be isolated systolic hypertension, where the systolic blood pressure is equal to or above 140 and lower than 90 millimeters of mercury. A couple of slides ago, I mentioned that we have other options to make the diagnosis besides the office measurement of the blood pressure. So the criteria to make the diagnosis in the office was the one I mentioned last slide. When we decide to have this ambulatory blood pressure monitoring, either by this I mentioned we're going to place for 24 hours, or the measurements the patient can make at home, the definition of hypertension changes. When we take into account the ambulatory blood pressure monitoring, if we take into account the average of the blood pressure after 24 hours, the criteria is going to be equal to or higher than 130/80. If we only take into account daytime measurements, 135/85, night times more than 120/70. And if we consider only home blood pressure monitoring, which is the monitoring the patient might do at his home, there is a very specific protocol for this blood pressure monitoring. We're going to take into consideration an average of equal to or greater than 135/85 to make the diagnosis of hypertension. Okay, and before we continue talking of hypertension, I'd like to make a small parenthesis and talk about blood pressure. And I'd like to ask this to you guys: what is the importance of blood pressure? Why do we need blood pressure? What is blood pressure? Okay. So blood pressure is a physiological variable that is going to allow blood, oxygen, and the different nutrients to reach the different organs and tissues in our system. So it's a variable, it's a physiological constant or a physiological variable that ensures perfusion, ensures the delivery of oxygen, of nutrients to the different organs in our system. And this blood pressure is going to be determined by different factors. Anyone would like to tell me how is blood pressure determined? Or what variables does blood pressure depend on?
Remember, you can also write the answers down and we can read it. So please don't be shy.
Okay. Blood pressure is a physiologic variable, as we mentioned, that is going to be determined by two main factors, which are going to be cardiac output is the amount of blood the heart pumps per unit of time, and peripheral vascular resistances, which is going to be associated to the vascular tone arteries are going to maintain. This interaction between cardiac output and peripheral vascular resistances is going to result in the blood pressure. There's always going to be an interaction between these two factors that allow the organism to adapt to its needs. For example, if we need to increase blood pressure, the cardiac output is going to increase, and this should increase blood pressure. If we need to increase blood pressure by a lot, we could increase both cardiac output and peripheral vascular resistances, and both of these together are going to increase blood pressure even more. On the other hand, if suddenly the peripheral vascular resistances decrease and we require an increase in blood pressure, the body could compensate by increasing cardiac output. Or if suddenly the cardiac output decreases, the body can compensate increasing peripheral vascular resistances in order to maintain a stable blood pressure. Each of these variables, both cardiac output and peripheral vascular resistances, are going to be determined by other variables, by other factors, by other physiological variables. So cardiac output is going to be determined by two main factors, which are going to be heart rate and stroke volume. Heart rate, I guess everyone knows what it is. It's the amount of times the heart beats per unit of time, usually per minute. And the stroke volume is the amount of blood the heart pumps with each beat. So if we multiply the amount of blood the heart pumps per beat times the heart rate, we're going to get the cardiac output. Once again, I just mentioned the body is going to need to adapt to the different needs of the organism. If the needs increase, we're probably going to need to increase the cardiac output. And in order to do this, we need the body to adapt. We are going to then regulate these variables with different factors. So the stroke volume is going to be determined by the preload. That is going to be the amount of blood that reaches the heart before each beat. This is going to be regulated by the amount of circulating volume. Inotropism, that's going to be the force of contraction of the heart, and by the afterload. So the higher the preload and the higher the inotropism, the higher the stroke volume. The higher the afterload, the lower the stroke volume. So the afterload is a force that opposes the blood from leaving the heart. So the higher this force is, the less blood can leave the heart. The lower the afterload, the higher the stroke volume. Usually the afterload in most persons is going to be determined by peripheral vascular resistances. So the higher the peripheral vascular resistances, the more difficult it's going to be for the heart to eject the blood from the ventricles. On the other hand, peripheral vascular resistances, as well as the cardiac output, are going to be regulated by different factors. So we're going to have both acute regulators, which are going to be hormones and situations that are going to modify both the cardiac output and the peripheral vascular resistances in the matter of seconds or minutes. And we're also going to have chronic factors that can modify both cardiac output and peripheral vascular resistances. But now, when we speak of time, we're talking of maybe hours to days to have these modifications. Anyone might think of acute mechanisms that might modify the cardiac output or the peripheral vascular resistances? Okay, so we have different alkaloid hormones, we have different endocrine hormones. So we have things like adenosine, prostaglandins, thromboxane, nitric oxide, which are very quick-acting hormones that are going to have very local effects. And we have other hormones like sympathetic hormones like epinephrine, norepinephrine, or parasympathetic hormones like acetylcholine, which are going to have a bit more intense and systemic effects, as well as endothelin that are going to modify the vascular resistances and the cardiac output in a very short period of time. We also have chronic factors that are going to help us regulate blood pressure, which are going to be the renin-angiotensin-aldosterone system together with all its hormones, the brain natriuretic peptides, vasopressin, as well as the concentration of sodium, calcium, potassium in our system are going to help us regulate the circulating volume and the vascular tone. And it's precisely this interaction between all these hormones that allows us to have a proper balance and to maintain blood pressure in adequate levels. When we have hypertension, which is this sustained increase in blood pressure, we're going to lose this balance between these factors that allow us to have normal peripheral vascular resistances and a normal cardiac output. We lose this balance and the blood pressure tends to increase. We tend to have an increase either in peripheral vascular resistances or in cardiac output or both. And this leads to hypertension. And when we talk of the treatment of hypertension, we're going to use drugs that act precisely on these hormones and on these substances that help us regulate blood pressure. Any questions or comments? So when we talk of the treatment for hypertension, we're going to use agents that are considered first-line agents initially. These are agents that have proved a couple of things. One of these things they have proved is that these are agents that reduce blood pressure. That's why we use them. But even more important than reducing blood pressure, these are agents that reduce cardiovascular events. These are agents that reduce myocardial infarction. These are agents that reduce stroke. These are agents that reduce the mortality and the morbidity associated to hypertension. This is why these agents are considered first-line agents, and this is why we use these agents first before using any other agent. There are going to be 5 groups of first-line agents, which are the angiotensin converting enzyme inhibitors, the angiotensin receptor blockers, calcium channel blockers, thiazide diuretics, and beta blockers. And I'm going to give a little introduction to these agents. And first, we're going to talk of one of the oldest agents used to treat hypertension. This is a group called thiazide diuretics. Thiazide diuretics are going to act in the nephron. And here you can see the nephron. They're going to act in the distal convoluted tubule. and they act in a specific transport protein, which is a sodium chloride importer. They're going to inhibit the action of this sodium chloride importer, and by blocking this transporter, we're going to reduce the amount of sodium and chloride that is reabsorbed. These are osmotically active particles, and if we don't absorb these particles, we're going to produce natriuresis, and with this, we're going to produce osmotic diuresis. So these are diuretics, they increase diuresis, and they're going to act through two mechanisms. They're going to decrease the amount of sodium in the body. This is going to reduce the circulating volume, and with this, we reduce the preload, we reduce the stroke volume and the cardiac output. This means we reduce blood pressure through this mechanism, and also by reducing the sodium content in the body, we vasodilation. By producing vasodilation, we reduce the peripheral vascular resistances, and to these two mechanisms, we're going to reduce blood pressure. The only problem with diuresis or with these diuretics is by blocking this sodium chloride importer, we're going to produce some electrolyte abnormalities. These natriuresis they produce, and this kaliuresis they produce can actually end up generating hyponatremia and hypokalemia. Also, they're going to inhibit the elimination, or they're going to increase the elimination of potassium and hydrogen as compensatory mechanism, and this can generate hypokalemia, as I mentioned, but also metabolic alkalosis. These are drugs that are excreted into the nephron by a transport protein called the weak acid transport protein, or the weak acid transporter. So they compete with uric acid, and this generates an increase in uric acid. Also, these decreased levels of potassium can end up producing higher glucose levels, and also an increase in lipid levels. So thiazide diuretics are very good antihypertensive agents, but a lot of metabolic and electrolyte abnormalities are associated to their use. So here we see the mechanisms through which they increase glucose levels, and it has to do with this decreased concentration of potassium that tends to modify the secretion of insulin by the beta cells in the pancreas. And the weak acid transporter that is needed for their excretion into the nephron, that is the reason why they increase uric acid levels. Which are the thiazide diuretics? Hydrochlorothiazide, chlortalidone, indapamide, and metolazone. They are considered low ceiling diuretics, and the reason they are considered low ceiling diuretics is because they produce a close to maximum effect even if we use low doses, and at the same time as we increase the dose, we see very small changes in the effect they produce. The next group of agents we're going to see are a group of agents that act on the renin-angiotensin-aldosterone system. This is a system that is going to be activated by renin, which is produced in the juxtaglomerular apparatus in the nephron, in the kidney, sorry. Renin is an enzyme that's going to metabolize angiotensinogen, and we're going to generate angiotensin 1. Then angiotensin 1 is going to be metabolized by the angiotensin converting enzyme, and it's going to produce angiotensin 2, which is then going to act in the AT1 receptor. And we're going to have several effects because of this stimulation angiotensin 2 produces in its receptor. We're going to increase the sympathetic activity, we're going to produce vasoconstriction, sodium and water retention, increased production of antidiuretic hormone and aldosterone. Plus, we tend to produce a pro-proliferative, profibrotic, pro-inflammatory effect. So AC inhibitors, as the name would suggest, are agents that act on the angiotensin converting enzyme. They inhibit the angiotensin converting enzyme. And through this mechanism, we're going to decrease the production of angiotensin 2. That means less sympathetic activity, less vasoconstriction, less sodium and water retention, less antidiuretic hormone, less aldosterone secretion, and less of this pro-proliferative, pro-fibrotic, pro-inflammatory profile. Plus, the angiotensin converting enzyme belongs to a group of enzymes called endopeptidase enzymes, which are enzymes that metabolize several peptides in our body. So one of these peptides is angiotensin 1, but another one of these peptides is bradykinin. Bradykinin is a vasodilator, which is normally metabolized by the angiotensin converting enzyme. And it's going to metabolize this bradykinin into inactive metabolites. Bradykinin is an enzyme, it's a hormone, that produces vasodilation, bronchoconstriction, and induces vascular permeability. When we block the angiotensin converting enzyme, that means we also have more bradykinin, and this means we're going to have more vasodilation, that means more decreased peripheral vascular resistances, and we can have these other effects that are going to produce some of the secondary effects associated to the use of angiotensin converting enzyme inhibitors. So in summary, angiotensin converting enzymes inhibitors are going to produce vasodilation, less sympathetic activity, less sodium and water retention, and all of this together is going to produce a decrease in blood pressure plus less of this pro-proliferative, pro-fibrotic, pro-inflammatory profile. Nevertheless, especially because of these increased bradykinin levels, we tend to produce angioedema, dry cough. Because of the decreased levels of aldosterone, we can increase the levels of potassium and produce hyperkalemia. And like any other antihypertensives, these are agents that can produce hypotension. Which are these AC inhibitors? Basically, most of these agents are going to end with pril. So here we have examples like captopril, enalapril, ramipril, perindopril, lisinopril. They had such good results with these agents that block the renin-angiotensin aldosterone system. They developed other groups of agents that also act on this system. The most important of these agents are going to be the angiotensin receptor blockers, which also act on this renin-angiotensin aldosterone system. But instead of inhibiting the angiotensin converting enzyme, they're going to inhibit the binding of angiotensin 2 to its receptor. By blocking this interaction between angiotensin 2 and the receptor, we're going to decrease the sympathetic activity, vasoconstriction, sodium and water retention, antidiuretic hormone production, aldosterone secretion, and this pro-proliferative, pro-fibrotic, pro-inflammatory profile. So we're going to produce all these favorable effects we saw with AC inhibitors without producing the effects associated to an increased bradykinin concentration. So we're not going to have dry cough, we're not going to have angioedema, only the possibility of producing an increased potassium level because of this decreased aldosterone concentration. Which are these angiotensin receptor blockers? All the agents that end up with sartan. So we have losartan, valsartan, candesartan, irbesartan, telmisartan as examples. The next first line agents we're going to talk of are going to be these calcium channel blockers. As the name suggests, these are agents that are going to block calcium channels, specifically type L calcium channels that are going to be found mainly in arterioles, but they are also going to be found in other structures in the body, like the heart and the gastrointestinal tract. Therefore, they're going to produce several effects. The main effect, which is the one we're looking for, is going to be the vasodilation associated to arteriolar dilation, but they also have the potential of producing constipation and a decrease in the heart functions like chronotropism, inotropism, and vasomotropism. This vasodilation, when it happens in excess with a quick-acting calcium channel blocker, can produce reflex tachycardia. And because a lot of these effects, like the decreased heart functions and the constipation they can produce by inhibiting the contraction in the gastrointestinal smooth muscle, are not as desired effects, we're going to have a subclassification of calcium channel blockers. So we're going to have dihydropyridines that focus mainly only in the vascular smooth muscle. These are agents that produce mainly a decrease in peripheral vascular resistances that can produce reflex tachycardia, headache, and edema as side effects. And we have non-dihydropyridines that produce just a little bit of vasodilation. That means less reflex tachycardia, less headache, and less edema, but they can produce constipation and heart failure-like symptoms. Once again, the dihydropyridines tend to produce these vascular side effects like reflex tachycardia, headache, and edema. These are agents like nifedipine, nicardipine, nimodipine, amlodipine, lecarnitidine. And we're going to have non-dihydropyridines that produce a much less intense vasodilation, but they can also produce constipation and decreased heart activity. The main advantage of these agents is they are considered metabolically neutral. Even if they are calcium channel blockers, they don't decrease calcium levels, they don't modify potassium levels, they don't modify glucose, they don't modify any other metabolic component. They have mainly vascular side effects, and because of this, they are very good for combination treatment. The last group we're going to talk of are going to be beta blockers. They're going to act by blocking the beta adrenergic receptors. We have different types of beta adrenergic receptors. The beta 1 receptors, which are found mainly in the heart. When we stimulate them, they increase the heart activity. They're going to increase also renin secretion. We're going to have beta 2 receptors, which produce vasodilation, bronchodilation, insulin secretion, and this sphincter and uterine relaxation. When we block them, we're going to decrease the cardiac output by decreasing the effects of the adrenergic hormones in the heart, and we're going to produce a very small increase in peripheral vascular resistances by blocking beta 2 receptors. So these are agents that are going to decrease chronotropism, inotropism, vasomotropism, lucitropism. They're going to decrease renin secretion. And at the other hand, they can produce a little bit of vasoconstriction, bronchoconstriction, insulin secretion, and they can also produce certain central nervous system side effects. For this reason, these agents can produce reduced cardiac output, bradycardia, and if we take that to an extreme, heart failure-like symptoms. They can produce bronchoconstriction and can increase the severity of chronic obstructive pulmonary diseases. They can produce vasoconstriction and increase the severity of peripheral artery disease. And because they tend to decrease the secretion of insulin, they can increase glucose by a bit. The central nervous system side effects, they can produce insomnia, nightmares, and depression. These are going to be the effects that happen with most of the non-selective beta blockers that block both beta 1 and beta 2 receptors. These are the beta adrenergic receptors, non-selective blockers like propanolol, pindolol, sotalol, timolol, gusindolol. When we want to decrease the side effects associated to beta 2 inhibition, we have beta 1 selective blockers that produce a lot less of this bronchoconstriction and vasoconstriction. But if we want to counter the vasoconstriction these agents produce, we have now the vasodilator beta blockers that can increase the production of nitric oxide like nebivolol, or that also block alpha receptor alpha-adrenergic receptors and produce vasodilation through that mechanism, like carvedilol and labetalol. Now, going back into the approach to hypertension, we have different options when we are screening our patients. When they have normal blood pressure, that is a blood pressure below 128/80, these are patients we should monitor at least every 5 years. When we have normal blood pressure but not optimal blood pressure, we should repeat blood pressure measurements every year, every 3 years at least. When the blood pressure is normal high, at these values of 130 to 139, 85 to 89, at least once a year we should register the blood pressure, and we can consider, or we should maybe evaluate a bit more to discard other diagnoses like masked hypertension with home blood pressure monitoring or ambulatory blood pressure monitoring. When the patient is hypertensive, we have to confirm the diagnosis either by home blood pressure monitoring, ambulatory blood pressure monitoring, or repeated visits in the office. And if it is confirmed, then we need to stratify the risk of the patient depending on the other cardiovascular risk factors the patient has, and if he or she has a hypertensive mediated organ damage, chronic kidney disease, diabetes, or cardiovascular disease. And the treatment is going to be decided depending on the risk the patient has. The higher the risk, the more aggressive the treatment has to be. The lower the risk, the less aggressive the treatment needs to be. So we can even start with just lifestyle changes in normal high blood pressure or grade 1 hypertension. And as the risk and the blood pressure increases, we're going to add treatment. Which treatment we're going to add? Usually, because most patients require combination treatment to be controlled, the recommendation is to start with a combination of an ACE inhibitor or an angiotensin receptor blocker together with a calcium channel blocker or a diuretic. If they are not controlled with this treatment, we're going to use 3 agents. Once again, ACE inhibitor or angiotensin receptor blocker together with a calcium channel blocker and a thiazide diuretic. And if he or she is not controlled with this, we're going to add a 4th agent, ideally spironolactone. And that's going to be it for today. I don't know if there are any questions, comments.
Doctor, while we expect if some students can make a question, I would like to make a question. Do you have any suggestion for the patient who has hypertension and diabetes? Because these are combinations very common in the practice, right? I don't know if something you can tell us about this kind of patients.
Yes. Patients that have diabetes tend to benefit a lot more when we use agents like ACE inhibitors and angiotensin receptor blockers, because they tend to have an extra benefit in this type of patients, especially patients that have proteinuria. If the patient with diabetes and hypertension has proteinuria, the most recommended treatment are going to be either an ACE inhibitor and angiotensin receptor blocker, combined with a calcium channel blocker, especially non-dihydropyridines like verapamil and diltiazem.
We have a question in the chat. I don't know if you can see
Yes.
it.
Regarding the diet, this is going to be part of the usual lifestyle changes. We have 2 main diets that are recommended as part of lifestyle changes, which is the DASH diet and the Mediterranean diet. These are 2 diets that are very similar, actually. These are diets that consist in a lot of fruits, vegetables, food that has omega-3 and omega-6 fatty acids. So we recommend also olive oil, we recommend nuts, we recommend peanuts, almonds, things like this. And we are going to recommend also within this diet a decrease in the consumption of salt, a decrease in the consumption of sugars, including sodas and Coke, all these things, all these carbonated beverages. And definitely we're going to reduce the consumption in flour and everything with sugar. But definitely it's a recommendation to use a DASH diet in patients with hypertension.
Thank you, doctor. I also have another question, if you don't mind. I don't know if you can tell us something about the same question about the patient with diabetes and hypertension, but the kind of medication with, I don't know how to say it, that's why I brought it down, sodium glucose transportation 2. I don't
Okay.
know what you can tell us about it.
Okay, sodium glucose type 2 transport inhibitors, SGLT2 inhibitors are agents that are not considered as antihypertensive agents. These are agents used mainly to treat diabetes, but these are agents that have shown to reduce blood pressure a little bit, somewhere between 3 and 5 millimeters of mercury. And these are agents that also reduce cardiovascular events, just like the agents I just mentioned, like ACE inhibitors, angiotensin receptor blockers, thiazide diuretics, beta blockers, and calcium channel blockers. These SGLT2 are agents that have shown to reduce cardiovascular events in patients with diabetes. So definitely this is an agent we should consider in any patient with diabetes, whether he or she has hypertension or not, but they can give us this extra benefit if the patient also has hypertension. But the main indication for these agents is basically any patient with diabetes. This is a drug we should consider, and they can give you an extra benefit if there is hypertension, but especially if there is heart failure or a high risk for heart failure in the patient with hypertension.
Okay, thank you so much. And if you don't mind, I have one last question. A lot of students here are of medicine, but we also have some of nutrition. And one of the questions, the most regular question they make us is what about the amount of water in the patient with hypertension? Do you have any suggestion for it?
Usually the amount of water should not be limited unless the patient also has heart failure. If there is no heart failure, the water intake should not be limited. What we should limit is the amount of sodium we consume. The thing is, most of this water we consume is going to be eliminated in the kidneys, unless there is a lot of sodium going together with the water. If a lot of sodium is consumed, then we're definitely going to increase the circulating volume, and we're going to increase the amount of water we retain. If we don't increase the amount of sodium, the kidney is going to eliminate that water without much of a problem.
Okay, thank you so much. Really clear. I don't know if anyone has more question. I think the Dr. Jose Angel Regla has a question. Doctor, you can open your microphone if you want to.
Okay, hello. Thank you for your talk. It was very great. I have a question because also one family had this problem for hypertension, and I think the hypothyroidism is a relation with a secondary hypertension, right? My question is how thyroid disease as a hypothyroidism affect the cardiovascular system? Because you explain different mechanisms, but I don't really understand what is really, how affect the hypothyroidism for cardiovascular disease.
When we talk of thyroid disease, the thyroid disease that is more associated to hypertension is going to be hyperthyroidism than hypothyroidism. So hyperthyroidism or how high levels of thyroid hormone are going to increase the effect of sympathetic activities on vascular smooth muscle and on the heart. So this means these are patients that are going to have an increased peripheral vascular resistance and an increased cardiac output. For these patients, the treatment is going to be to control the thyroid disease, and if the hypertension persists, we should also treat the high blood pressure. Sometimes we need to start with treatment of hypertension because it takes a bit longer to control the thyroid disease. So that is the mechanism. There are some idiosyncratic effects we can see in certain patients with hypothyroidism, where the blood pressure might also increase, but these are not very well described mechanisms. For the most part, and the most common manifestation of thyroid disease would be when we have hyperthyroidism, then we tend to see tachycardia, increased vascular resistances, and hypertension as a result. So this is going to be even part of a syndrome called this thyroid storm, which is characterized by tachycardias and at least in part tachycardias and hypertensive crisis.
Okay, thank you.
You're welcome.
Thank you so much. I don't know if anyone has more questions for the doctor. I think it was really objective and really easy understanding. We have really appreciated, and I would like to thank you so much for being here. I know you have a lot of things to do, and Luisa Paulina has one question. I don't know if you can write it down, or Paulina, do you want to open your microphone? I don't know.
Okay, thanks. I just wanted to ask the doctor if he has a preference over the European or the American guides for the treatment of hypertension.
I have a bit of a preference for the European guidelines because they are a bit more explanatory, easier to understand, and also the Mexican guidelines are based on these European guidelines. So it's a lot more practical to use them here in Mexico.
Thank you.
You're welcome.
Thanks, Paulina, for asking. I don't know if anyone wants to ask. It was a really good webinar. Thank you so much, doctor. And thank you so much for giving us something of your time, because I know you're really busy. No?
You're welcome. It was my pleasure. So I think that's it for today then.
Yeah. So thank you so much. Thank you everybody for being here. I hope you can join us the next webinar. Remember, it's going to be Wednesday at 7 p.m. So the webinar in English is for practicing our English. Don't forget that. So thank you so much. Thank you for much, doctor. Thank you so much for everybody. So have a good night.
Thank you for the invite. Have a good night.
Bye.
Bye.